Good morning, good evening, or good afternoon. Welcome to our session on hybrid governance, exploring it in rapidly evolving health ecosystems. We have 4 presentations today. I must say that we have some apologies also. Megan Arthur from Edinburgh University and Antonia Magnoni from McGill University and Dr. Upendra Boyani from Institute of Public Health, Bangalore, could not make it today because of health reasons or family reasons. But we still have 4 presentations and they all revolve around these questions. So they are all drawn from empirical field research from diverse settings and contexts, and they map the use together of different governance lenses, frameworks, and arrangements. They identify gaps and challenges of the use of those approaches, and they will discuss the potential for theoretical and methodological innovations. And we will also together at the end of the presentations consider implications for changing policy and practice. We'll go ahead as follows. We'll have each presentation and we will try to have a Q&A after each presentation. The first presentation is from Dr. Vatsala Ilesinghe from Sri Lanka and Ryerson University in Toronto. She's a PhD candidate. The second is Dr. Pragati Hebar from the Institute of Public Health, Bangalore, where she's a Wellcome Trust Fellow. The third is Dr. Shinjini Mondal from McGill University. And then we will have Dr. Aloysius Senyoyo from Makerere University School of Public Health. I will first now give the floor to Dr. Vatsala Ilesinghe. Dr. Vatsala, you have the floor. I will stop sharing my screen.
Thank you, Sarah. It's great to be here virtually in HSR 2020. Although when we first signed up, this is not how we envisioned this conference to be, but it's really great to be here. And so today I will be doing a brief presentation about our work in Sri Lanka, really looking at the health sector response to intimate partner violence in Sri Lanka. So before I moved to Canada, of course, I lived in Sri Lanka for most of my life. And this work is a project that built on more than 10 years of work there. So it was really about doing a collaborative knowledge building and sharing work in line with the collaborative governance model that we're talking about today. So as you may know, intimate partner violence is any act of abuse by a current or former intimate partner or spouse. And in the work that we did in Sri Lanka, this was really looking at women's experiences of intimate partner violence by a male partner. And so for some time, we've known that the healthcare sector can play a significant role in addressing intimate partner violence. But what we have not really figured out is how do we coordinate or collaborate in dealing with a problem that cannot really be addressed by one organization or one government department alone. So to give you a little background, I'm sure you know Sri Lanka is a small South Asian country with a population of about 21 million people. And compared to the other regional countries, they've done pretty well in terms of educational attainment and other health indicators like life expectancy, neonatal mortality, and maternal mortality. In terms of the status of women, it's of course, as anywhere in the world, it's not static, it changes in response to various situations and contexts. And when we look at intimate partner violence specifically, you know, Southeast Asia is a region which has about 37% of women reporting intimate partner violence. And Sri Lanka is, of course, in this region. And our studies have shown that about 1 in 3 women report IPV with wide regional variation in prevalence. And of course, this experience is contextualized based on the war that we've had there for 30 years and women's experience of both displacement and opportunities for work within and outside the country. And of course, most recently with COVID-19, we know the risk of intimate partner violence has also increased. So within this context, our work was really to look at the health sector response to intimate partner violence specifically, and the integration of both the health and non-sector services in a formal institutional context. So essentially, this is a case study. We reviewed publications. We also surveyed about 750 healthcare providers across Sri Lanka. And more importantly, we brought together stakeholders to gather their perspectives in a collaborative setting. This included not only clients, but both the state and non-state sector partners. To give a little overview of the health sector response, the earliest documented health sector response to providing intimate partner services was relatively new. It's in 2002 when they began. And as in any other developing country, the health services are, of course, overcrowded. There is lack of space, lack of privacy. And the Ministry of Health takes sort of an overall governance over health policy formulation and financing. And in-hospital care is limited to what we call a one-stop crisis center, where they aim to provide all services for women experiencing abuse in one place. Now, when we apply a collaborative governance lens to this collaboration, historically, what we see is that services for women were begun by faith-based organizations like the Good Shepherds, the Salvation Army, and other women's rights groups as early as 1924. When the government wanted to implement these services, they began what they called the gender-based violence desk. This is literally a desk, which was really an informal collaboration between the NGOs and the government, where they would have one or two of their counselors working in a hospital setting, providing really organic services for women in rural and war-affected areas. It was quite effective in the sense that they allowed women to seek services within the hospital, but also to access those that were outside. That was really led by the non-state sector. Under the policy framework of a national plan of action, the government then formalized this institutional structure to create what we call a one-stop crisis center. When this change came about, it was now a Ministry of Health-led, a hierarchical top-down organization of services, where, unlike in the past, when the NGOs led the services, the healthcare providers were given a quick one-day training to take on some services that were really not equipped or experienced to provide. And it was really resource heavy because an already struggling healthcare system was now trying to create specific centers for women seeking services in a hospital setting. So in collaborative governance, we talk about this concept of a collaborative advantage. Really, is there an advantage in the multiple sectors engaging in this collective decision-making process? For it to be effective, it has to be more deliberative, consensus-oriented, and directed towards the achievement of a shared goal. Ideally, in instances where there is public and non-public stakeholder participation and management of resources, this is where we could look at collaborative governance as an effective tool. Ansel and others have identified critical variables that lead to good collaborative governance. And out of these, I think the only two things that were working well in this instance was that they had prior history of cooperation, and in cases where it worked, there was good leadership. But other than that, there was no incentives for stakeholders, and there was a huge power and resource imbalance. And when we look at the services in more detail, what we realized is that the institutional governance designs were not conducive or compatible with allowing non-state actors to have a place at the table. And the resource imbalances were really attenuated in this model. So really, this is making a case for governance analysis in low-middle income settings. But there are two really key barriers to this. One is a conceptual barrier where there should be space to understand that civil society actors and bureaucrats bring distinctive knowledge and perspectives, and whether they are able to bring these different perspectives for transformative change. And when we were doing the study, what we found was that there are really methodological barriers because the same hierarchical structure that does not allow for sort of collaborative knowledge sharing also limited our ability to do research, right? So they were like, we don't want you to evaluate this program because we know it's working. So I think the advantage was that we used multiple sources of data. We had both qualitative and quantitative analysis, and we used participatory methods so that through a consultative process, we were able to gather information that helped us to understand what are the gaps and limitations of this collaborative governance model. So our recommendation is in the short term would be that such collaboration should be informed by governance analysis and theories. And there's really a lot of gaps in this area with regards to providing intimate partner violence services. And as a start, there should be a framework that not only sort of outlines the process for decision making, but also resource allocation and management. And there should be really an investment in time and resources into building a cross-sector trust and respect before they go into developing the programs and sort of developing a shared understanding of what these outcomes are. And we published this work in a couple of papers. If you would like, I can send details of those. So thank you so much.
Thank you so much, Dr. Vatsala, for this very clear presentation on collaborative governance embedded in the historical CSO state relations in Sri Lanka. And it shows very much the importance of institutional fit or institutional design. Now, I would like to invite the people present in our panel for any questions, clarification, as well as technical questions on this presentation of Dr. Vatsala.
Hi, this is Shinjini. I'm a PhD student at McGill University and a fellow panelist. Because if I think about the issue of intimate partner violence, I think the things that strike me most is that the issues of power imbalance, because those, I would not call them victims, but that population is already marginalized. And when you are proposing something of a collaborative governance, how do you see their voices are representative and not get lost, and they are able to voice like their concerns and their needs? So what would be your more specific recommendation or a thought to maybe more inclusive to those voices?
Thank you, Shinjini. I mean, a very important question. Whether it's collaborative or not, when we were providing intimate partner violence services, that would be the key, right? Because already you're in a power imbalance and you feel that you have been victimized, or you feel that you are receiving end of it. So in whatever services, we try to make sure that we address that. And in the hospital setting, the biggest struggle was that it was already built in a way that reinforced these power imbalances, and you would come into a hospital in these particular settings that we examined. There was predominantly male doctors in the outpatients departments, and there were very few room for the services that would be normally provided by nurses or midwives that they are used to. So by moving it into the formal hospital setting where those imbalances were already present, it did not sort of help to remove these conditions of oppression that the women felt. So one of the key recommendations would be to make a deliberate effort to make sure that those who are involved in providing these services are not only trained, but then they have had the experience as well as the sort of the structure to be able to do these services, in making a deliberate effort to kind of dismantle that power relationship.
Okay, thank you very much, Dr. Vatsala. Any other questions? I'll give you a minute. Okay. Okay, then we'll go to, thank you very much. We'll go to Dr. Pragati Hebar. Pragati Hebar is from the Institute of Public Health in Bangalore, and she will introduce herself. Thank you.
Hello, everyone. And thank you, Sarah, and thank you, Vatsala, for the great start. It's a pleasure to be here and to share with you a bit about our work from tobacco control implementation in India. So to start off, a brief context, we are the second most populous country with over 1.3 billion people, and the number of tobacco users is also extremely high, with 266 million people using either the smoked or the smokeless forms of tobacco, which are extremely prevalent in India. Several Indian states also produce large quantities of tobacco. So states are spread across south, the west, the east, each producing different varieties of tobacco, which can be used for either the smoked varieties or the smokeless forms. With such a huge burden or prevalence of tobacco, tobacco control may seem like quite an uphill task. And just to look at how the government has responded over the years towards this. So quite early on in 1975 itself, we had the Cigarettes Act, which was mainly covering areas of promoting tobacco and restricting the advertisements. But it was extremely weak, and even its enforcement provisions were weak. Later, over the years in 1980s, 1990, the World Health Assemblies, there was a growing concern of tobacco, and member states were urged to protect non-smokers mainly from tobacco smoke and its hazards. In India, in around 1993, the cabinet had approved for a comprehensive tobacco control bill to be passed. And it took a decade of consultation, of research, of engaging with multiple stakeholders, being such a large producer of tobacco, to finally come out with the Cigarettes and Other Tobacco Products Act, or COTPA 2003. And this was an extremely comprehensive act covering various provisions. And the following year, we were one of the early signatories of the Framework Convention on Tobacco Control. And this is an extremely ratified public health treaty across the globe, with over 180 countries party to it. And in 2008, the NTCP, or the National Tobacco Control Program, was launched. And this program provided the structure and the funding for tobacco control in India. So just to recap, I think the context, like globally, even in India, there's a growing burden of NCDs. And to add to the complexity, the factors such as extensive tobacco industry interference at various levels, right from the local implementation level till the national level, the federated governance system, the democracy that we have, which is decentralized. So the health being a subject which can be addressed at the state has its own challenges. And some of the favorable external factors have been the ratification of FCTC, as well as the growing pressure in the World Health Assemblies. The content of the policy that we have mainly is for COTPA, there are four main enforceable provisions, which are prohibition of smoking in public places, prohibition of direct advertisements, restricting access to youth of tobacco products, and mandating pictorial health warnings on tobacco products. And the National Tobacco Control Program gave this structure, three-tiered structure, which formed a national cell, a state cell, and a district tobacco control cell. The various processes followed over the years were that rules were notified once COTPA was enacted. Various guidelines and operational manuals have been produced. Extensive training of officials has been done. There have been squads tried for enforcement, and review at various stages, at district, at state, as well as national levels. But as we see here, there is quite a variability in implementation. This is just a snapshot of the 2 rounds of Global Adult Tobacco Survey and how the proxy indicators of implementation have varied. The bars on the left show states which have worsened implementing certain provisions, whereas the bars on the right show the improvement. And as you can see, it's a very mixed bag. Each state has fared quite differently, although it's the same law that governs the entire country. To start off our work, we started with exploring the various frameworks and models that explain implementation that exist, and we found quite a few, of which some key ones I'd like to show, which shaped our formation of our own framework. So the first one is the active implementations framework, which spoke about the different stages as well as drivers, which were crucial. Then there was the diffusion of innovation framework, which within service organizations, but this helped us to internalize the outer setting, the inner settings, and the various factors that could impact implementation. There was also a framework by the International Tobacco Control Project, which spoke about how the policy progresses. And then there were individual level factors such as the behavior change wheel, as well as the core capabilities framework. And lastly, in 2000 and 2019, there was a framework by Connie Ho et al. On implementation fidelity, which spoke exactly to tobacco control and the factors that are key to it, such as the industry interference, the institutional capacity. So all of these factors and another framework by the Campaign for Tobacco Free Kids, which covers implementation and says that the three major components of implementation are education, enforcement, and review mechanisms, helped shape our initial theoretical lens. Some challenges that we faced during this process of developing our own framework or aligning with any existing framework was that these multiple levels that we speak about in tobacco control, right from the individual level, which takes into which addresses the behavior change which is required, till the settings that the different states work in, the different governance arrangements that they work in. So there, the current existing frameworks were unable to capture this multiple level dynamics that exist. And also the socio-cultural context in India, how tobacco is seen as a cash crop since several years, although it was introduced to India, and the political economy of tobacco control, and also the varying interests, right from the tobacco control advocates up to the users, as well as the government and the tobacco industry. And finally, also the different tools that exist and their application in LMIC settings have been, the data is scarce. So what we propose to do in the coming 2 to 3 years, this is work in progress, is a realist synthesis on tobacco control policy implementation in LMIC settings, and also a realist evaluation of COTPA and NTCP program. And through this, what we aim to do is to develop a refined theory on implementation, particularly of tobacco control in LMIC settings. Towards the end of this work, what we hope to add is to the areas of implementation research as well as realist evaluation. And in the course of the program itself, we aim to develop a community of practice of practitioners, of implementers, of enforcement officials from various departments, and also hold multiple consultations to inform and improve practice. So thank you, Sarah, and thank you everyone for your patient hearing.
Thank you very much, Pragati, for this very interesting presentation on the quite contested situation of tobacco control, which has a long history since 1975, and also for comparing those frames on implementation and showing their gaps, and also that idea of regional consultation and setting up a community of practice. I will first give the floor to our audience. Does anyone want to ask a question for clarification or for technically to Pragati? Okay.
Hi.
Yes, hi.
Hi, my name is Catherine Connor. I work at ThinkWell, and I am very impressed with both the performance data that was shown in the slide before she showed all the frameworks. The level of detail of that data is amazing. and with the proposed structure for implementation research and these regional teams, et cetera. My question is there any consideration of comparing locations where you do the implementation work with other locations where maybe you will not work, and trying to draw any conclusions about the effectiveness of your effort in you know your locations compared to locations where you may not be working? I don't know if that type of impact methodology would be appropriate in this case, but I just wondered if you were going to look at that possibility. Over.
Thank you. Thank you for the excellent question. So the current study design is one that where we're planning to compare 3 states of India, where the implementation, we're trying to find cases which are the most varied. So one of the best performers, as we go by that graph, where a few of the top performers versus the ones that have not performed so well, and the ones where implementation has been average. So the current methodology plans to take into account these 3 Indian states. And we also plan to look at it in a way that the contextual factors in each of these 3 would be quite different. So one may be from the southern region, another from a hilly or culturally different region. And so this would add to the sort of richness that we would be able to capture of the contextual factors. But since it's a national law which is applicable across all Indian states, we plan to use this sort of a comparative methodology where 3 cases would be selected. I hope that answers your question.
Yes, I
Perfectly.
think so.
Thank
Yeah.
you. Exciting.
Are there any other questions from the audience? Okay, then I will ask a question myself. How do you see in India realist research evolving? Is there a lot of research realist at the moment? Is there room for a regional community of practice on realist research?
Thanks, Sarah. So I think when I had started this work somewhere in 2019, it was still quite new, and there was, in fact, especially within the policymakers, there was a lot of interest in this at the national level as well, because they say that now we know what is working where or what is not working where, but we don't know why. So we have all the data that shows that, okay, this is the level of proxy indicators, implementation, but we want to know why. And according to them, they feel they have tried their best, but they're still hitting a roadblock. So I think within the implementer and policymaker circle, there is quite some expectation out of this methodology. And within the research community, there is quite a bit of interest. So in the initial stages of the project, we had conducted a realist workshop for our own capacity building, and we were amazed with the sort of response from several Indian states, young researchers who had signed up and participated. So it's a growing field, and there's definitely a scope for a regional community of practice. Yeah.
Very exciting. Okay, I think we will continue now with our story on tobacco control implementation, but then from a networked governance perspective, multi-level, grounded in district level implementation with Dr. Shinjini Mondal. Shinjini, you have the floor.
Hi, thank you. I'll just share my. Thank you, Sarah, for the introduction. So I will build some of the context that Pragati has already shared, and that's why I go after her. So she focused more on the national level and on the state level, where I go to the actual implementation units, which are the districts, and try to see how conceptualization of these implementation as governance networks work and enable us to study these difficult implementation units that are occurring in a multi-sectoral policy. So, sorry. Yeah. So my entry into looking at tobacco control comes from the background of it as a multi-sectoral policy. So multi-sectoral policy implementation is characterized by like joint working arrangement across institutions and policy sectors, forming effective linkages, and like developing a mechanism for coordination. And they are quite, the structure of these networks or this implementation structure is quite actor oriented. And these matches more like networks and can be termed as issue of networks or coalition. And the interaction between these networks and actors actually determine how a policy may succeed or not. So moving towards conceptualization as a network governance. So when we look at the network, so the traditional governance arrangement are challenged due to its multi-sectoral nature, which are traditionally like top-down and command and control mechanisms here, because it is not only one department that you can follow those kind of chain of command, but you have to work across the different sectors and departments. So this kind of requires a different kind of relationship building, which is horizontal, and a distinct kind of governance, which is more horizontal or network from. And it is based on exchange of resources and trust, and rather than the top-down command and control mechanisms. However, these networks and different actors are embedded in different power differential, have different interests, but they have to negotiate and work towards reducing conflict and making these things to work towards a common goal. And some of these cooperation and collaboration of goals and interests doesn't happen in their own accord. So much of the focus has been how these networks can be steered where they can provide that kind of implementation results and network efficiency. So on the research setting and methodology, so I focus again on India on a state level, which is Karnataka, southern Indian state, which have had like a quite good implementation in terms of tobacco control policy. So I focus on two districts, District 1 and District 2. So District 1 and 2 differ in terms of their compliance to tobacco control law, COTPA, as Pragati had earlier indicated. So District 1 had a better compliance compared to District 2. So we also wanted to see how the networks look different across two different districts. And we focus on the bottom level of the pyramid, which is the district level. So in terms of research design, it's a mixed methods explanatory study where quantitative phase is followed by a qualitative phase. So for the quantitative phase, we did a social network analysis across the district level implementers, across all organizations and all departments. And we looked at the measures of network centrality, density, reciprocity, and generated sociograms, which are the network diagrams. All the network diagrams are really helpful to give you an overview of how the structure of the implementation looks and how actors are placed within the implementation. But it kind of doesn't explain why you have certain sector structure and why certain actors are central. So in order to explore those kind of network patterns, we did a qualitative phase where we interviewed those key actors and also observed some of the key activities at the district level, which are the district coordination committee meeting and the tobacco enforcement activities at the district level. So on the first part, when we look at the social network graphs, so we asked three kind of questions or in the social network survey. So we asked their pattern of interaction for the tobacco control. So this is the first graph. So here you can see a network of different organizations. So a gray line between two dots indicates the relationship, and the size of the node shares how many people actually go to that person when they have to implement tobacco control and interact with that person. So the bigger the size of the node, you would see more people go to that person if they have to implement the tobacco control. And also you could see some similarities and differences across the two graphs. So yellow is the color for health sector. So health sector people are quite central in the network, both in District 1 and District 2. Although in District 1, you would see the central person is highly, I would say, centralized and influential and able to communicate with the other sectors, other people in the network. Whereas you see a relatively small circle for the District 2, but in District 2, you would see like circles 77, 44, or 60, which are the sub-district level people, administrator at the health sector, who are more active in their own respective sub-districts. So when we ask the next question in terms of who did they go to for information when they need any kind of information for tobacco control network. So you see a number of nodes have reduced, nodes or actors, the circles have reduced because many people said we don't need information, we just follow what we have been told. So you see a similar pattern is repeated in the information seeking where the health department remains very central. And in the District 2, these are the sub-district administrator that remain quite central where everybody goes to them and also the central actors. The key thing in the information is that the health sector central actors also go to have a very good communication with the state level support system, which is the middle level of that triangle, the state cell. And when we ask the third question in terms of decision making, so the number of actors further reduced. These are more like the middle or the higher level manager who have to do only the decision making. So the things you would note is that similar dots are connected to similar nodes, so which would kind of signify that the decision making is quite restricted to their own department. Although people reached out to the health department, but the decision making part is restricted within their own department. And also the health sector, if they have to go to any decision making at the district level, they have to rely on the departments like police and revenue and finance, which so the highest person of these departments are highest administrative authority for the department. Sorry, on the sorry. Okay. So if I now move to the qualitative part, so we conducted interviews across both districts to be able to help us figure out why certain people are acting as network leaders and some people are brokers. So network leaders were district admin, mainly district administrator or the tobacco control designated administrator for the tobacco control, and also lower level people were implementers. For network brokers, we see that broker system more at the sub-district level, and these are sub-district level health administrator. So the common characteristics are like, which are shared across these two groups are, they are passionate, self-driven, they have in-depth knowledge about the program, they have a sense of accountability, commitment, they are local to that district and sub-district and have been living there for maybe like 17 to 20 years. And they have a history of long engagement with the tobacco control program. The unique characteristics for network leaders and brokers is they are credible, trustworthy, resourceful, more also in terms of information and able to help in terms of monetary resources, and they kind of provide mentorship. When we look at a lower level implementer who are important in the network, that trustworthiness is important, but they are more approachable to other people. They are very informative and they are able to convince people at the higher level to be able to participate in the network. If we look at what have been the main challenges and enablers, so the main motivation for participation has been that the relationship should be mutually beneficial. Like people from the department of food safety would participate in the tobacco control implementation activities, because they also have to go on different raids to see how plastic ban is being implemented, and they kind of schedule these activities with the tobacco control activities. So if it's beneficial for both the department, it really works. At the district level, there is a sense of camaraderie, because many people have been residents of those districts and have been working in the district for last 17, 20, and we also had participants who were there for 30 years. So there is a friendship, and they want to respect that and help each other. The thing that helps is also the routinization. So initially there is it's very difficult to ask other departments to participate, and a lot of formal letters had to go. But once it becomes a routine activity, it's just a phone call away. They don't even need a letter or a directive. For tobacco control, I think it was very unique, because there's a lot of evidence that tobacco is bad and you should not use tobacco. So everybody had a motivation to participate towards a societal good. So nobody would directly refuse and say, oh, we don't want to participate. They will usually give some excuse. So there is a larger conviction. In terms of challenges, the self-department workload is our biggest challenge, which is coupled by the HR challenges, vacant posts in other departments, and support from district administrators. As I mentioned, the highest level from the police and revenue, they chair the district level coordination committee meeting, which is like every quarterly, and they follow up on the activities happening in the district. So that kind of support from the district administrator is very helpful to propel the program. This also relates to the departmental hierarchy, where like the police and revenue agency, where district collector is the main or the highest administrative authority, they have a hierarchical relationship, and their people do respond to them better if it's more like a request from a health department. And the last one speaks to the same, that initial engagement is very time consuming. So what are the considerations for governance research? So SNA, I do feel that social network analysis is a useful tool to able to give a visual representation of those relationships that are being present. And if you can repeat it over the time, you can also capture how the networks change over time and what factors actually bring change in the network. It can be used by the district level or a state level authorities for governance practices. Like in District 2, you have sub-district administrators who are also the keynote. So if you have to strengthen the program in the District 2, you will try to engage those nodes more into the program. So this kind of network diagnostics is helpful for people to able to visually see and strengthen the program. Some of the bigger questions that I had while trying to complete and bring together this work is, at district level, we have these networks, and as Pragati informed and told that at state and national level, I also have one part of the study which deals with the state and national, there are many actors. So it's not that the district level actors are not connected with the state or the national level. So for information, the district level relies on the state level a lot, whereas the state level and the national level actors are highly connected. When I did my interviewed the national and state level actors, I think they were hardly that one didn't know another. So they are very well informed and connected. So the governance or influence of implementation is not only restricted to district level, but also is connected to state and national level in some way, and which makes me think about a multi-level governance type of component. And maybe if we can also do an SNA, which is at a national, state, or district level, so we will be able to see what kind of connections are across the both three levels. But also for governance research, I think one of the main consideration is about power, because that departmental hierarchy and the ability of health department to convince other departments to participate remains quite debatable. And there's a lot of complexity involved in this kind of implementation. And the main question is also around accountability, that if it's a health department program run by a national, as a national program, how much accountable are the other departments to this program, and how can we ensure their accountability? These are the questions that I've been thinking about, like how we answer these. I would like to thank you, my supervisor, 3CS committee members, my local partner and study collaborator, Institute of Public Health, State Anti-Tobacco Cell Karnataka and district official, and study participants. Thank you.
Thank you, Shinjini, for this very fine-grained analysis, looking at and pointing out that district-level implementation is also very much dependent on the support that and the multi-level governance focus needs to be brought into that district-level implementation, looking also at the state and at the support from the national level. And a very interesting idea of doing much more longitudinal research on this, because social network analysis and then the qualitative research attached to it to explain network governance. It's very interesting longitudinally, in the sense that what you see here is that long-term engagement of civil servants in certain administrations will help trust building and will help implementation a lot. This is an important element. In a lot of low and middle income countries, there's a lot of rotation of civil servants and sort of a precluding of this long-term trust building, and this might hamper intersectoral coordination. Questions to the audience? Questions of the audience, sorry. Who would like to try?
Yes, I have a question, Sarah. Thank you, Shinjini, for this nice presentation and sharing your work. I was wondering, I was very much excited to see that social network analysis, but I was wondering, how the time factor was captured in that social network analysis, because as Sarah was also saying, there is a frequent turnover of bureaucrats. And so how that was captured, in a department, it also depends on a personality, that implementation. It also depends on the actors' interest and motivation. So if that keeps changing over a period of time, then as now it appears the SNA is the snapshot of a specific time period, and which time period it was. And if the SNA was done over a period of time, was there any changes? Is there any explanation around that? So that is one question. And the other question is about, I felt there's a lot of emphasis on state actors. And in the last slide, you also mentioned about multi-level governance. So was there any role for non-state actors in your analysis? So these are my questions. Thank you.
Thank you, Meena. Yes, I think those are very pertinent questions. I would start with the social network question. So the social, as you correctly pointed out, and it is correct, that the social network is like a horizontal cross section. So it captures only that period of time, and it is not sensitive. I would say you would have to continuously do it to be able to notice change in the social network, which was not possible in my case, because getting surveys from these different departments at the district level was very challenging. Initially, I had thought maybe I can repeat it and see, but I think that was going too much on that time period. But I tried to compensate that in my qualitative research, and I didn't mention it, but yes, these district administrators are very important. So when we did the the social network analysis, and when we did the interview, there was change in district administrator. Like in District 2, which was not so good performing, the initial district administrator who was present was not very convinced with the tobacco control program and was not supportive of it. But once the district administrator changed, the new district administrator asked for the district level coordination committee meeting, and it kind of kick-started the more action in that district. So those kind of changes I was not able to capture through SNA. So that is a limitation, but I try to get these kind of more elements which are respond to time, and like how, and also to see like the SNA was done between last year, January to like maybe around March, in those 3 months. And this program has been in the district for last 2-3 years. So the qualitative phase tried to capture that time gap in it. The second question, mainly, if I remember correctly, it's around the non-state actors. So at the district level, we did see some role of the NGOs or the non-state actors in terms of academic institutions playing part. But I think I also did a national and a state level, where I did see a lot of role in terms of advocacy and in terms of generating evidence, in terms of supporting the implementation, both at the state and the national level. And I think tobacco control is quite unique in terms of having that kind of civil society and non-state actor support. At the state, at the national level, the influence I saw was more, but at district social network analysis, I did not come across that much. Maybe it may be more biased because I only selected 2 districts where there may not be those kind of big NGO groups present. So that be that kind of limitation to selection of districts.
Thank you.
Did I answer all your questions, or did I miss anything?
No, it's fine. Thank you.
Okay, any follow-up questions on that? Because that's a very interesting discussion. Okay, I think we'll have to go towards Aloysius. We're also maybe starting to be a bit short on time. Shinjini, yes?
Yeah, I will operate the slides for Aloysius because he's having some technical difficulties. So he will just give me a prompt to change to next slide. So I will operate slides for him.
Okay, Aloysius.
Good evening, everybody. It is good evening here in Kampala. So I'm glad to be part of this discussion. I hope you can hear me well.
Yes, we can hear you.
Great. So my work is focusing on coordination with the government as a way of moving towards collaborative efforts to achieve health and development objectives. It is part of my PhD undertaking.
Aloysius?
And I want to say to me, collaborating with United States actors without due attention to internal government coordination. And that is the main motivation for this work. Next. Shinjini?
Yes.
Yes. So in perspective, here we see the traffic police in Uganda trying to direct traffic flow. But underlying that is the realization that we need police to achieve road safety and prevent road traffic accidents, which are a major burden of disease to the health and a major cost to health system here in Uganda. Next. Also within this is understanding that within the SDG era, health has been conceptualized as an outcome of effort from different sectors and in a way linked to the other development goals. And that goes for us to see how we can appreciate the interdependencies as well as the roles that health sectors have to play in achieving these health outcomes. Next, please. Quickly. Again. Yes. So what this means to us is that we need to think about mechanisms or ways in which to bring these contributions to bear, but also realize what could be the constraining factors preventing their optimal functionality. And so this is the motivation for the work I'm undertaking. And I want to share about next, Shijin. Yes, just for us to understand that when I mean coordination mechanism, I refer to strategies, instruments, and structures where different organizations come to target, but also to be able to harmonize their different approaches as well as their different priorities. And this is aimed at creating coherence, reducing duplication and contradictions within policies and between what is specified in documents and what is implemented. I want to say that from the public sector administration and organizational theory, we have three logics around which coordination mechanisms are conceptualized. We have markets, hierarchies, and networks, hybrids. So much of what my friends have looked at in terms of coordination through networks. But I'm going to focus more on hierarchies and how power and control within the central government apparatus is working in Uganda to attain cross-cutting objectives. Very quickly, next. Yes, so this study is focused on Uganda, mainly the central government level. It comes from interviews I've done, 26. Sorry, there's an error. The non-health sector representatives are 16. And so we have had interactions with people within the health sector and non-health sectors. Those agencies with central coordination functions like Office of the Prime Minister, Office of the President, as well as other sectors like transport and agriculture. This has been supplemented with review of documents. Next. So this is what we are seeing. For starters, we have formal coordination mechanisms that operate at the core cabinet level. They are committees, they are processes that bring different ministers together. And within these are the efforts to mainly coordinate policy development. At the interministerial level, we have mainly task forces and technical working groups that operate within different ministries. We also note that there are many processes around which coordination is being organized in government. There is a comprehensive national development planning framework headed by the National Planning Authority. And through this, they are able to align the different sector plans to the national development plan. But also the tools and such as MOUs, contracts are being pursued across different thematic areas to attain coordination. One important thing to note that within the government setting, many actors consider coordination to be synonymous with the office of the Prime Minister without realizing that even at their level, they have roles in coordination. The main constraints to this are the issues of mandates and conflicts, and this in a way underscore the power differentials between the different sectors and how horizontal relationships can be built. The issue of budgeting for coordination, specifically our respondents noted that there are no specific funds for coordination. Much of the funds go into implementation, but budgets. And in one particular case, one was concerned that how do you budget for tea? Because many times coordination is synonymous with meetings. There is an issue of corruption and inadequacy accountability arrangements in that people are unwilling to be come together to coordinate as a way of preventing others to see what they are doing, which might be contrary to the expectations. Within the Ministry of Health, there are many concerns that we see, issues of many departments. The ministry is considered to be very big. There are too many projects and people are not anywhere for them to connect with other sectors. But they are also considered to have too much money, which in a way makes them a little proud and less enthusiastic about working with others. non-state actors. But also we see less advocacy with the Ministry of Health reaching out to others. There is a very prominent role of donors within this space, and we see them funding, but also promoting particular thematic efforts like nutrition and malaria. Next, please. Just for me to summarize for you, these are the main drivers and considerations within the coordination dynamics. Much of the coordination is done by liaison officers and coordinating units. So even within the ministry, there is a desk for example, nutrition, there's a desk for water. Even within the office of the Prime Minister, there's an officer who is in charge of, let's say, social development. Even within the National Planning Authority, which oversees the overall planning, coordination planning, coordination during planning, there is an officer for social sector, for macroeconomics. So in a way, this segments the planning, but also you find that because there are many coordinators, then you need to think of coordinating the coordinators. But also the issue of effective representation. How does this liaison officer feed back into the processes back where they meet other sectors, but also internally within their respective sectors? Issues of politicians and bureaucrats. You know that ministries are headed by cabinet ministers who might have their own priorities different from those of the bureaucrats. The others are regarding capacity issues for the coordinators. I give an example of 18 sectors. Government is divided into 18 sectors, and they are not within the Ministry of Health. You have 15 technical working groups. All these are supposed to coordinate. How do you bring them together? Next. Hello. Next. Yes, just for us to capture the ongoing efforts, there's efforts around thematic areas, nutrition, malaria, but also government is moving towards mainstreaming multi-sector planning through the new National Development Plan, which started last year and ends in 2015. But issues of resourcing and evidence to support multi-sectorality are still deficient. Next, please. Next. Go run through them. Yes. So just to say here that there is a very supportive policy and planning framework for multi-sectorality. Next. And in particular, there is a national coordination policy designed by the Office of the Prime Minister to support its role in coordinating government business. Next, please. Next. Yes. Next. Fundamentally, here is the issue of systems for monitoring and evaluations, which are lacking and in a way undermine the coordination efforts within government. And finally, next, please. Yes, I propose these as key considerations for moving towards coordinated government action. The issue of coordination within government versus government coordinating with non-state actors, I think, is critical. And how do we balance the two aspirations? Issues of resource management and pressures around sectors and budgets are critical. Accountability across different ministries, government, and agencies, but also who is supposed to convene who, and the issues of power differentials are critical. And fundamentally, how do we frame issues and solutions to cultivate and entice or induce multi-sectorality? Thank you for your attention.
Thank you very much, Aloysius, for keeping your cool, and Shinjini also for sharing the PowerPoint work. I found it very funny that you were saying that there's budget for tea in terms of, it sort of makes sense because you need the meetings for the trust building, and the trust building takes time. Also, rarely do we look at the central level and at the policies that were set around coordination. And here you clearly have a coordination policy. And it's true that it's important also in coordination, and even more so, that these things do not happen spontaneously, but there's also supposed to be a leader who has to convene, and who is this sort of meta-governor. Are there any questions? Shinjini.
Thank you, Aloysius, for your presentation. I could relate to many of the components and of your presentation. So one question for you, this is something what I observed. So as a part of creating any multi-sectoral action or policy, they create structure in form of coordinating committees and designated members. But apart from those formal mechanisms, I could find like informal mechanisms, especially when I took a networked approach where people use their like social capital, their agency to engage people in the implementation work. So how do you see the space between this formal and informal like go? Did you come across any informal mechanism apart from this formal like coordination platforms?
Thank you, Shinjini. This is very pertinent. I would say that the informal mechanisms are also very important, and these are mainly built around interpersonal relations. One of the things that I found very fascinating is that there are people, civil servants are rotated across different departments and ministries. I give an example of policy analysts who are supposed to coordinate policy development with different ministries. And as they move through the different agencies, they build networks and relationships which they draw on for their further work. I have an example of someone moving from one ministry to become a commissioner in another, and another one moving from the health ministry to become a staff within the office of the prime minister, whose role is the coordination function. So I think they build more on these relationships, but also related to that is the concern about these relationships in a way, if they don't work and people have had bad experiences working with another person, they are less enthusiastic about moving to further coordination arrangements. The other, of course, rotates around the work of brokers, like the people in academia, the donors who bring these different sectors together using the resources, expertise, and financial or otherwise to facilitate dialogue and coordinated planning and joint action.
Thank you, Aloysius. That was really helpful.
Thank you, Aloysius. I think that is very interesting, especially the moving through different departments, which can also be applied maybe in to help interdisciplinary collaboration in academia. Okay, anyone else? Questions?
Yes, I have a question.
Yes, Mina.
Thank you, Aloysius. Nice to see your PhD work. It's very interesting and very important, I feel. So Sarah was mentioning about meta governor. Who's that? I'm taking that question to a next level. So in your experience, in your PhD, whom do you think is in the best place to steer multi-level coordination or multi-sectoral action for health? That is one question. The other one, now we have so much, there is so much hype about health in all policies approach. So to what extent other sectors are oriented towards or sensitized about the importance of health? Maybe you would like to listen from your experience in your PhD project. Yeah, I stop here.
Thank you so much, Mina. These are very interesting questions. I would say that using the case of Uganda, we have different meta governors depending on the issue at hand. The issues of funding and financial resources, the Minister of Finance in a way becomes an overarching leader. When it comes to planning and development of sector plans, we have the National Planning Authority. Issues of implementation, you have the Office of the Prime Minister. And there are some areas like human resource where the Minister of Public Service takes more or less a more hierarchical role. So, but overall, then you have the office of the president and the cabinet. Generally, I would say these would be sufficient, but then we have also to be issue specific so that we don't overburden the apex. Otherwise, the capacity of the coordinating entities also gets worn out. The issue of sensitization around multisectorality, I would say government in Uganda is moving towards mainstreaming multisectorality, not only for health, but also other cost-cutting issues. So areas I've told you about the program-based planning and budgeting being explored in this financial rather period 2020 to 2025 to see how best even other cross-cutting issues in addition to health could be coordinated and integrated within government business. Yeah, thank you.
Thank you, Aloysius. Are there any specific questions for Aloysius still? We have 5 minutes left, but I don't know if we get cut off or not. Anyone?
Hi.
Sarah, there is a, sorry, please go ahead. Sarah,
Sorry?
there is a question on the Q&A session. You can read that for Aloysius.
Okay, wait. I'll go to the screen. Please put your question here. Okay. Okay, Shinjini, I cannot see it. Can you read it out, please?
Sure. I think someone was asking the question, so maybe that person can ask and then I can read the next question.
Okay.
Yeah, okay, I can speak if I can see. I see now participants are allowed to unmute themselves. Hi, I'm Helen Schneider. Hi, Sarah, and hi, panelists, and thanks for interesting presentations. So, Aloysius, that was really fascinating. The question I had was the extent to which you think that these new national frameworks and mandates are real game changers, and do you think they will overcome the overwhelming imperative towards siloed sectoral functioning that, you know, we all recognize is a key issue, particularly at subnational and local levels, and what is needed, do you think, to shift this in a way from the bottom up as well? And I mean, I took the point about the incredible fragmentation that you speak about as well. So that was my question.
Thank you, Prof. Happy to have you on our session. I would say the new frameworks are a big experiment. One of the main concerns has been the disconnection between plans and the resourcing, which are the budgets. And we hope that with these alignments, we shall have better outcomes. I would say this is an area that is of interest for me in my PhD, and I hope to pursue it as a case study. In regards to subnational level efforts, I would say there are some distinctive elements that may make coordination at the subnational level a lot easier in respect to the relationships people have and the fact that they stay closer together most of the time, unlike at the central level. But then also you look at them, the upstream forces that bear down on them from the national level and the donors. So there still needs to be support rather to the coordinating entities at the subnational level, especially those with legitimate roles like the office of the chief administrative officer here in Uganda, or the district health officer who's in charge of the health business. But we have also had experiments with the One Health here in Kampala, where capacity around One Health and working together has been built, especially around the COVID response, which promises to be a nice experiment for us to examine further.
Thank you, very interesting, yeah.
Thank you, Aloysius. I think we look forward to your case studies because you're going to study this in several different health teams. We have 1 minute still. I don't know if we're being cut off, but we had also a question for you. Maybe it's sort of something to continue the conversation and to contact any of us, Shinjini, Aloysius, and so on about. I'll try to share my screen. So do you see it? Do you see my screen? So I will speak out loud. So
Yes.
we were wondering what sort of governance methodologies and tools you are using. Any other theoretical frames that you have used and have not been mentioned and that were pretty successful, especially in the implications for practice, because that's why we're doing this governance research, of course. If there are any quick reactions, we'd like to hear them. And if not, we'll have to say good evening, good afternoon, good morning, I don't know. Anyone has a quick remark, end remark? No? Okay, then I think we had a hugely interesting discussion. And really there are some cross comparisons to make and so on. And I think, I very much hope that we can continue this conversation between ourselves and see each other soon. Have a good evening. Oh yeah, there is this website that I had to notify you about regarding future scenario building for health systems. Good evening, and thank you for attending our session from all of our participants, from Shijili, Aloysius, Vatsala, and Pragati.
Thank you.
Thank you, and best everybody.
Thank you
Bye.
for your participation. Bye.